So, doctor, it's a pleasure to meet you. So, we want to know, how did your interest in pharmacogenetics begin?
Well, I think my interest in this field started when I was a young physician. Back when I was trained as an intern and resident in internal medicine at the University of California, San Francisco Medical Center, and I was just amazed and sometimes alarmed, if you want, when we were treating patients and it was unpredictable how they would react to drugs. Moreover, when I asked my superiors, they knew very little about drugs in principle. And we had a group of people there in the house, clinical pharmacologists. They were called Ken Millman, Howard Morelli. They wrote the first big book on clinical pharmacology. And they started to help us with these patients, when we had a problem with the drugs. And they were informing us about the drugs. This also triggered me to then do a fellowship in clinical pharmacology after my first clinical training. But that was only one thing. The other thing was that I was doing research with a group on a disease called intermittent acute porphyria, which is a genetic disease of heme synthesis. And drugs triggered in that disease, several drugs, all the drugs that induce cytochrome P450 trigger acute attacks of neurophysiological function. And it's called a pharmacogenetic disease. So I was able with that group, or we were able with that group, to actually define the defect and how drugs actually produce these acute symptoms. So this really raised my interest in pharmacogenetics.
Perfect. Okay. Thank you very much. Wonderful. So, what do you think nowadays is necessary for the clinical implementation of pharmacogenetics?
Well, that's a pretty big frustration, if you want. It's been very difficult. It's been true that the implementation in practical daily clinical medicine has been very slow. Even now, it's still so that most of the pharmacogenetic genotyping and all these type of things, they're done in medical centers at universities, and very little. Where we see major advances are in the pharmaceutical industry. They've suddenly realized that that developing a new drug and having a biomarker, a genetic biomarker, another biomarker, to see if the drug gets to the right place, if it actually works, and these type of things, is a big help. And in fact, of the 35 drugs that were approved last year by FDA, 12 drugs had such biomarkers, including genetic biomarkers, so 35%. So industry is starting adopting, these in terms of precision medicine, as you want to call, to have a drug together with a companion diagnostics, which is a biomarker that they can use in clinical studies and later on then in the clinic. And but if you look at the numbers, they are terrible. If you look at the numbers, recent studies have shown that, for instance, in the UK, I think in one study they showed that if they looked at people that get a drug prescribed that has in the label pharmacogenomic kind of information of what the physician should do, only 10% were actually genotyped that should have been genotyped. And they also found that people over 70, 90% of people over 70 are exposed to at least that one drug that has pharmacogenetic implications. So the numbers are pretty clear, but how to do this, how to get this into clinical practice is continuing to be very difficult, very frustrating.
Yes. And in other countries, it's even worse, right? Yeah, I'm from Brazil, and well, there we have some more problems than UK. when we compare to another countries, right? But yeah, we have a lot of challenges to pass.
Yeah. But of course, it depends, of course, on the infrastructure in a country. If you have the infrastructures, you have it in medical centers, but if you have it outside as well, and let's say in developing countries, there's another major issue which I find very interesting and very challenging, and that is all the things we know about big numbers in genotyping or genome sequences. They all derive from white Europeans,
Yes.
9%, and just a few from other countries. So
Mm-hmm.
we don't really have very good numbers about many countries in which not a lot of genome sequencing has been done. And this is now being realized very much, because if you then go into a database and to look at your finding, it may not be adequate for this particular population. That is the big run now for a pangenome, a human pangenome. First one was published 2 weeks ago in Nature. Where they looked at 47 different sources of genomes, and they found major differences, of course. So in some of these developing countries, we don't even have good numbers about the frequencies of these type of pharmacogenetic polymorphisms.
Yes, but we're on our way to.
I think so. I
We're
don't know
working
about
on it.
Brazil. I don't know about Brazil.
I
I
hope
really don't.
it's soon. um, well, how do you think big data or bioinformatics will impact pharmacogenomics?
Well, that's a big thing. I mean, I think bioinformatics in general, and the data science, if you want, are of increasing importance in medicine, in all fields of medicine, not just in pharmacogenomics. And I think they're going to play a major role in the future, because we all moving into electronic medical records, exchange of data between centers, between groups, it's all consortia, in the future for rare diseases anyhow, but also in pharmacogenetics. We mostly have many consortia now all over the world. And they're, data science and, dealing with informatics and creating databases that really apply for these patient populations is going to be very important. No question.
Yes. And what about the importance of human resources training pharmacogenomics?
Well, that's a difficult question. Of course, we've always tried to train young physicians as early as possible in their curriculum, show them examples, test them themselves, so that they get them interested, in this whole thing.
Yeah, of course.
And there's also there are two things to this. This was the physicians on one side, that the primary care physicians, ultimately the specialist physicians, but there are also in some countries the pharmacists play a major role. Like in the Netherlands, for instance, it's the pharmacists that run the whole pharmacogenetics, primary care thing.
Mm-hmm.
And they work together with the physicians, but it's the pharmacists that do the genotyping, that give advice, that thing. So it's these two professional groups that we have to concentrate on, depending on the country and how the pharmacy business is organized and how physicians are trained. These are the
Mm-hmm.
two things, the resources that we ultimately need to implement pharmacogenetics.
Great. Would you like to study something else in the laboratory?
Well, I don't work in the laboratory anymore. I had to give up my team some time ago.
Mm-hmm.
So I'm still going to the medical center. I talk with a lot of people. But if I do something very intensely now, is to see how artificial intelligence and machine learning is going to be ultimately applied to many fields of medicine, including, of course, pharmacogenomics. Because if you take a drug effect, it's influenced by many things, not by genetics. You have
Yes.
all these things like diet and age factors, hormone factors, and so on that play a role in ultimately So we go into the kind of we ultimately need as multi-algorithm systems that try to analyze a patient with all the different factors influencing his drug response in his particular situation with his pathophysiology. And this you cannot do, once we have data and data and data, you have to go into these multiple algorithm decision making where you can actually help ultimately clinical decisions. What drug, what dose is the best in this situation?
Yeah, this is huge.
Yeah, it's a huge field, but it's interesting, and
Yes,
it's making rapid progress,
yeah, and complex.
I guess you know about chatbots, Chat GPT,
Yes.
So I put a few drugs into there, to see what the drug information is. If I put a drug in there, like I don't know, put some opioid in there, morphine or something, and you get a very good summary of everything that's known about this drug.
Yeah.
So this is coming.
Yes, it's here. It's already here. Well, thank you very much. Should we put our eyes in genetic variants of nuclear receptors to explain some inter-individual variability on drug metabolism?
It's actually a very good question, but I don't have a good answer really, because when we worked on CAR and PXR, the nuclear receptors that are involved in the induction of drug metabolizing enzymes and transporters, and but we didn't find really, major, differences between people which we could reduce to genetic influences. The big influences were hormonal, fasting, things like that, and not really differences in nuclear receptor structure or function. So I don't have a good answer. I don't think there's a lot there. There's, of course, other things. If you take the hormone receptors, like estrogen receptor, and I would be very interested in looking at the estrogen receptors in terms of genetic variation, because we have this, for instance, this overrepresentation of women in Alzheimer's, underrepresentation in Parkinson's disease, and it has to do with estrogens very clearly. So it could be that there is something to, that's interesting in terms of these hormone receptors. If you think that almost 70% of Alzheimer patients are older women.
Yeah, that makes sense, of course. Yeah. Well, and finally, can you join us? What are your hobbies?
Well, I used to be a very avid skier. I'm living in Switzerland, so I grew up on skis basically. But now
That's
I'm too old, so now I do not that much, skiing, downhill skiing. I do more, cross country skiing now in the winter. But I have
Isn't
other
it a
hobbies.
little bit dangerous, no?
No, it's not dangerous at all. Not dangerous at all. Well, the downhill is dangerous. I agree. That's why I don't do it anymore at my age. I can still ski, but if I fall down, I can't get up. So that's the problem. I have other hobbies. I started 10 years ago. I started sculpting with clay and plaster. And I do make sculptures with body shapes, abstract body shapes, things like that. And my teacher in my head is Jean Arp. I like his sculptures, so I do things like this. And so that's another hobby I have.
That's great. Thank you very much, Doctor. It was a pleasure to meet you. We
Well,
appreciate your time, your availability.
Well, we would like to thank to Dr. Urs for his time and his kindness in this project. We invite you to read the paper of the tribute to Dr. Urs in the journal Drug Metabolism and Personalized Therapy. And we will see you in the next interviews of Leaders in Pharmacogenetics. Thank you.